afternoon. I am Mary May Regeo. I am a medical student at Southwestern University, FINMA, and I will be assessing your head, ma'am, and that includes your eyes, ears, nose, mouth, and of course the neck. So, will that be okay, ma'am?
Yes.
Okay, so, can you please state your full name, ma'am,
Sheldon M. Argeo,
and your date of birth?
October 23, 2002.
Okay, so, can you please sign this informed consent, ma'am, stating that you agree to our procedure and assessment? Okay, thank you. The static finger wiggle test to assess the visual fields of the patient. So, first we will position ourselves at arm's length away from the patient and let the patient close the one eye of the patient and cover the other eye. Please cover your left eye, right eye. Okay, then we will test your left eye. So, can you please say yes, ma'am, once makita na nimo ang ato ang finger? Okay? So, we should also cover our eye to reciprocate the patient's eye. So, tell me once makita na nimo, tell me yes if makita na nimo ang atong finger mo, ha?
Yes.
The other eye, please.
Yes.
So, when the patient's left eye repeatedly does not see the fingers until they have crossed the line of gaze, a left homonymous hemianopsia is present, or if there is diminished visual fields, then it could indicate that the patient has a glaucoma. So for our patients, is she can immediately see the finger. Our patient has intact peripheral vision and in both eyes and in all fields. Now we are going to inspect the conjunctiva and the sclera, so noting the color and if there is presence of nodules or swelling. So to examine the bulbar conjunctiva, we must pull down the lower lid, noting the color and if there is presence of nodules or swelling. And for the palpebral conjunctiva, we will pull the upper lid up. So the same, we will take note of the color also and if there is presence of swelling or nodules. So we will do also at the other side of the eye. So normal vascularity in this sclera is normal and present in most people. So if there is redness in the conjunctiva, then it could indicate that the patient has conjunctivitis. So our patient has pinkish and normal conjunctiva, and there is also minimal blood vessels visible, and the sclera is normal and no presence or no jaundice noted. So now we will going to test the pupil reaction to light. So normally our pupils constrict in response to looking at the near object. So we need to shine the light from the temporal side of the patient and not directly in front of the patient's gaze. So this is to ensure that the pupil's constriction is a result of the light reflex. So, ma'am, lantaw ra sa ako, straight, ma'am, ha? So, we will look for the direct reaction, or when the pupils constrict in the same eye, and the consensual reaction when the pupillary constriction in the opposite eye. Okay, so for our patient, the patient has direct and consensual reaction to light reaction. So right after assessing the pupillary light reaction, we will now proceed with assessing the corneal light reflection. So we will also use the pen light. So once we will shine the light, we should be able to see the sparkle, and that is the light reflecting of the cornea. So the light should be seen symmetrically on each cornea. So if there is a symmetrical light reflection, then it could indicate that there is a weak extraocular muscles or the patient has strabismus. So, lantaw ra gyapon straight sa ako, ma'am ha? So there is for our patient there is a symmetrical light reflection of the cornea. So right after we will now going to assess the cardinal directions of gaze or the 6 extraocular movements. So ma'am, kanang imo ra gyapon i-follow ni ang pen light ma'am ha. So I will kanang up na ding dili midline ra gyud ang imuhang ulo. So dili ka mulingi ha. Sige. So this is the 6 extraocular muscles test. So the patient has no lead lag or there is an intact extraocular muscles. So now that we are done with our eyes, now we will proceed with the ears. So we will first inspect the auricle for any deformities or presence of skin lesions. So right after, we will now proceed with inspecting the ear canal and the eardrums using our otoscope. So by inserting the otoscope, we will grasp the auricle up and gently pull it backward and insert the otoscope. Now we are going to see what's inside the ear. Okay. So our patient has a patent canal free of redness and there is a minimal cerumen noted. So we will also inspect at the other side of the ear. So again, we will pull the auricle and pull it upward and backward, then slightly away from head. So on the right ear, there is also a minimal cerumen noted and free of redness and drainage. So if the canal is swollen or if there is it is narrowed or there is tenderness, then it could indicate that there is otitis externa. Now we are going to assess the patient's hearing through whisper test. So we will stand 1 to 2 feet behind the patient and we will whisper her and she will repeat the whispered numbers. So pwede nimong tabunan imong right ear, ma'am. So we will first test the left ear of the patient. So i-repeat ang letters, ma'am ha, or ang numbers. 4 1. Okay, so the other side, ma'am, the right. Okay, so
3, 2, 4.
4. Okay, so the patient can repeat whispered words or whispered numbers in both ears. So now we are going to test for sound localization by Weber test. So we will use the tuning fork or the improvised tuning fork, and we will set the fork into light vibration by stroking it between the thumb and index, or we can also tap it here or in the forearm just in front of our elbow. So then after is we will put the tuning fork firmly on the patient's head or in the mid forehead. So the patient normally should hear the sounds in both ears or in the midline or kanang sa tunga. Then if there is unilateral conductive hearing loss, the sound is heard or lateralized to the impaired ear, so it could indicate that the patient has otosclerosis or otitis media or perforated eardrum. So let us try it. So we can put it here firmly on the above the head, and we can also put it here in the mid forehead. So if the patient cannot hear the sounds, or you can repeat the procedure. So asan mo madunggan ang sound, ma'am?
On both sides.
Okay, so normally the sound should be heard on both sides. So next is we will test for the Rhine test. We will compare the air conduction and the bone conduction. So normally the air conduction is heard longer than the bone conduction. So to do this, we will place the lightly vibrating tuning fork on the mastoid bone behind the ear, and if the patient can no longer hear the sound in the mastoid bone, then we can immediately, or we can quickly place the fork on the ear canal, and until the patient can no longer hear the sound, and we will time it and we'll compare it to the other ear. So if the patient has markedly or defer the AC and the longer AC and BC, then in other ears there is unilateral hearing loss. And if the AC is shorter than the BC, then it could indicate that the patient has otitis media. So normally it should be, the AC should be longer than the bone conduction. So we will try it. Yeah, please tell me, ma'am, if di na ni madunggan. Then sa other ear. And please don't forget to time the kuan kung nusa niya na nawala ang sound. Okay, so as we can see, she has lateral hearing on both sides, so positive for Rhine's test. So now we are going to inspect the nose and the paranasal sinuses. So first we will inspect the anterior and the inferior surfaces of the nose for any deformities or asymmetry. So after inspecting the anterior and the inferior surfaces of the nose, we will proceed by inspecting the inside of the nares with our otoscope. So to do that, we will tilt the patient's head back, so so that we can insert our speculum. So we will insert it gently into each nostril. So we will see the inferior and middle turbinates if we could be able to see it, and the nasal septum if there is any change of color. So ba mo insert ko sa otoscope, ha? So for our patient, the septum is located midline. It is moist and no lesions noted inside. So if there is change of color, if the inside is reddened or it is swollen, then it could indicate viral rhinitis. So now we are going to palpate for the sinus tenderness. So we have here the frontal sinus and we have here the maxillary sinus. So we will palpate it, and will note if there is tenderness. So we will press up the frontal sinuses. So this is under the bony brows. So avoiding pressure of the eyes. So we will palpate it. So, and the maxillary sinus. So if there is presence of tenderness together with a facial pain and pressure or fullness on the maxillary or the frontal sinuses, and together with other symptoms like as purulent discharges or smell disorder, and especially if it is greater than 7 days ng symptoms, then it could indicate that the patient is having an acute bacterial rhinosinusitis. So it involves the frontal and the maxillary sinuses. So for our patient, there is no local tenderness noted. So it is normal. We are going to inspect our mouth and the pharynx by first inspecting the lips, the gums and the teeth, of course, and we will also inspect the oral mucosa. So we will let the patient open her mouth, and with a good light, and of course with the help of our tongue depressor, we will inspect the oral mucosa for color, ulcers, white patches, and if there is any nodules, and if there is also central cyanosis or pallor from anemia. So, can you please open your mouth, ma'am? So, our patient, she has pink and moist and intact mucosa. So, right after, we will now proceed with inspecting the lateral margins of the tongue, and we will use gauze. So, we will ask the patient to protrude her tongue, and we will inspect the lateral margins of the tongue, and feeling for any induration, and if there is red or white patches also. Pwede ni mo ipagawas imuhang kuan, ma'am, dila. Thank you. So, for our patient, there is no presence of white patches. So, if there is any persistent nodule or ulcer or red or white patches, we could suspect that the patient has an erythroplakia and leukoplakia, and it should be immediately biopsied. Now we are going to palpate our lymph nodes, and we will note if there is any tenderness, because if there is tenderness, it indicates an inflammation, or if there is a hard or fixed nodes, it could indicate malignancy. So we will first palpate the preauricular lymph node. So here, at the front of the auricle. And of course, next is the posterior auricular at the back of the auricles. Next is we will also palpate for the occipital, which is at the base of the skull posteriorly. So we will palpate for any tenderness. And tonsillar lymph nodes. And the submandibular, just here. And the submental. We will also palpate the posterior cervical lymph nodes and the supraclavicular lymph nodes at the above of the clavicles. So we didn't feel any tenderness. So our patient has supple and non-tenderness and no masses noted on her lymph nodes. So now we are going to palpate the patient's thyroid gland. So we can either do this anterior approach or the posterior approach. So I will be doing the posterior approach. So first, we will locate the thyroid isthmus below the cricoid cartilage of the patient. So here. So, pwede kang swallow, ma'am, sa imong kuan. So, we will feel for the thyroid isthmus rising up after the patient swallowed. So, here we can palpate. We will palpate the right thyroid gland. So, pwede kang turn imong head na. We will palpate the thyroid gland, the right thyroid lobe, and the left thyroid. Okay, so now that we have palpated our thyroid gland, the patient has soft and firm thyroid lobes, and there is no enlargement or tenderness noted. Now we are going to inspect the tracheal position. So we will inspect the trachea for any deviation from its usual midline position. We will palpate the trachea. So if the patient has mass, or if there is mass in the neck, it may cause tracheal deviation to one side. So it will raise suspicion of conditions like mediastinal mass or atelectasis or a large pneumothorax. So for our patient, the trachea is in midline and no deviation noted. So we will also auscultate over the trachea. So this allows for the subtle counting of the respiratory rate and establishes the point of reference when assessing upper and lower airway that causes shortness of breath. So we will listen for a stridor for upper airway etiologies. So this is we will now auscultate over the trachea for any stridor.